Assalamu alaikum. It's a privilege to be giving a talk today for RheumaCon. I'm very thankful to Dr. Tafazzul for inviting me again to this year's talk. It's always an honor to speak for him. Our relationship goes a long way. He was my mentor during my medical school, and he's a very close friend, like a brother. So again, thank you very much for that. And I would like to introduce myself. And this is my introduction. I'll try to give you my introduction first. So my topic today is autoimmune myositis. I'm Shakaib Qureshi, and I've been a rheumatologist for many years working in USA. Initially started as a section head of a big rheumatology teaching program in Delaware, where I served as a section chief for about 15 years. And also my job was to teach medical students and residents, medical students from Thomas Jefferson and also from Philadelphia College of Osteopathic Medicine, and also from New Jersey, and Delaware athletic students from the University of Delaware. And also after doing all that, I was finally in 2018, I have shifted my focus to Pakistan and have been working in Pakistan, as well as serving as a director of rheumatology in a program in Utah, where I'm partly serving there as the medical director for rheumatology. And also I'm teaching medical students there for a Rocky Vista Medical Center. I'm on their teaching faculty. So why I chose autoimmune myositis is that being at the tertiary care center, I've seen some very, very interesting cases of myopathy, clinical myopathy, autoimmune myositis. And recently, in the last few years, I've seen almost like a whole series of myositis patients, especially since last year. And so I thought that we will refresh this important topic because there's a lot of, it's an evolution, a lot of more information is coming. So I wanted to take this opportunity to tell you a few things about it. The first case, in fact, is a very interesting case, which I saw, in fact, for the first visit was a televisit. And it was a very interesting patient where he presented, he's a male, 50 years old male who presented with joint pain and swelling. He lives in a very small town. I'll show you that in a second. But his main presentation, which is the pertinent positive, is that he presented with generalized aches and pains, swelling of the joints, which started about 4 months prior to he presented to us. His pain was mostly focused in the ankles, knees, wrist, and shoulders. And along with that, he had significant symptoms of morning stiffness lasting for multiple hours. So obviously with these symptoms, the differential is wide. We think about inflammatory arthritis. This patient lives in Manila, Utah, which is a very small place. In fact, I visited this place. To go to this place, you have to drive through a place called Flaming Gorge. And this very small town is at the border of Utah and Wyoming, very unknown place to most of the people in the world. And when you're driving through it, you go through some very gorgeous kind of, natural views. Scenic beauty is amazing. So this person is a math teacher, and he has 11 children. Most of the people, you'll be very surprised, in Utah have 8 to 10 to 11 children. They believe in very large families because their religion is Mormon religion. So one of their belief is that they want to have big families as a part of their religious practices. So, and another very thing unique about Utah and Mormons is that almost none of them smoke or drink alcohol. So the life becomes easier for rheumatologists to treat them, because as we all know that smoking can induce a lot of inflammatory arthritis or inflammatory process, and also alcohol use can become a contraindication to the usage of most of our immunosuppressant medications, or becomes risky. So past medical history, nothing special other than usual stuff of hypertension, hyperlipidemia, obstructive sleep apnea, and reflux. His medication list included the antihypertensives such as amlodipine, hydrochlorothiazide, some inhalers he was taking, antifungals, topicals, and testosterone replacement also is very unique in the rural areas of, in USA. It's been quite liberally used and replaced. So he was on testosterone replacement and his vitamin D and potassium. So family history was positive for lupus in the sister and otherwise arthritis in the parents. Review of systems. So in review of system, the most important part was the, that there was some dry cough and shortness of breath. Also, he complained about some fatigue. There were no fever or chills or night sweats though. And he was positive for GERD, and Raynaud's phenomena, importantly, was negative. And you can see the rest of it. There was no focal muscle weakness. The review system, a further pertinent review system was that to expand them, he had dry cough and shortness of breath, which was lingering on for the last 2 years. This is something that retrospectively, when we asked him in detail, he said, no, I actually was having shortness of breath and cough for about 2 years. And, it was very slowly progressive, but finally there was a physician assistant in that particular area who finally did x-rays and CT scan of the chest. In fact, that was the person who referred the patient to us based on probably that this patient had inflammatory arthritis. So let's send him to a rheumatologist. Other thing he complained about was when we asked in detail was that he mentioned that he has some rash on the hands bilaterally, which started about 6 months or more prior to his presentation. Vital signs, pretty much normal other than slightly high blood pressure and slightly high BMI, as you can see. Physical examination. The most important part in the physical examination, obviously, when we are zooming into rheumatology differential diagnosis, was the lung and the joint examination in the skin, where most of his symptoms were positive. So the chest examination showed that he had bilateral crackles in the lower lung fields. And he also had clear-cut synovitis of his wrist joints, and he had pain on the flexion and abduction of the shoulders, leftwards and right. And skin was the very interesting part. So on examination of the muscles, otherwise his strength was pretty good. No major muscle weakness was observed in both the upper or lower limbs. The skin part was very interesting. So he had roughening of the skin of the bilateral palmar aspect of the digits, and similar skin finding was present on the extensive surfaces of the elbows, of the knee joints, and also had some edema of the feet and some palmar nodules. This is his picture. As you can see, he's a teacher by profession, so not someone who is involved in a lot of manual physical activity. So you can see his hands, and they do remind you of a syndrome. Most probably now you know what I'm getting at. If there are a big chunk of rheumatologists in the audience, you can see how his fingers are and how his thumb, especially the right thumb, is. These are his initial presentation in July of 2020. As you can see, you can see the redness around his MCP areas and some in the PIPs as well. You look at the elbows, where there's also similar erythematous findings of scaly finding. And look at his feet, especially in the heel area, around the MTP joint area, and also, as you can see, in the sole of the MTP area. Similarly, I would like you to see his knee joints. You can see the roughening of the skin, the scaly skin. So while we are waiting for all the workup, we gave him a short trial of steroids while we ordered some labs and imaging and results of the imaging. So imaging, which was already done at an outside facility, was not a high resolution CAT scan, but this is what it showed. We had to bring it down to our facility to have a second reading. And you can see that he has, bilateral lung disease, especially in the lower lobes, where you can see the interstitial lung disease findings consisting of some honeycombing, but some ground glass opacities as well. So hand and wrist x-rays, as expected, did not show anything clear-cut, no erosions, nothing special. Labs. So labs that we ordered showed that he had a normal renal function. The liver function was normal. Hepatitis panel that we normally order in all our autoimmune inflammatory syndromes came back negative. TB testing was negative. ESR was 16. TSH with the normal limits. Uric acid normal. Rheumatoid factor and anti-CCP were negative. Double-stranded DNA was negative. Smith antibody, anti-Smith was negative. HLA-B27 was negative. The scleroderma antibodies, all the three came back negative. The PMSCL and RNP antibody came back negative. NK antibodies were negative. The ENA panel was negative. Rho and La antibody was negative. The CPK was barely elevated around 227. He was a big guy. Lab results. So this is the most important part. We were expecting, in fact, the preclinical probability of this antibody was pretty high. We were expecting this to come back positive because the disease syndrome that we had in our mind has this antibody found in the majority of the patients that we are suspecting to have the syndrome that we will talk about. And as you can see, the rest of the autoimmune antibody myositis panel was negative. So our conclusion was that this patient has what we call antisynthetase syndrome. And antisynthetase syndrome is an autoimmune disease characterized by antibodies against many of the amino acid transfer synthetase of the cell, with clinical features that may include interstitial lung disease, non-erosive inflammatory arthritis, myositis, Raynaud's phenomena, unexplained fever, or mechanics hands. So the most interesting part, as we can see in this patient, which was the tip-off when we saw him, was inflammatory arthritis, along with very typical of mechanic hands, very typical mechanic's hand. He's not a mechanic, but his hand looks like very typical of what a mechanic's hands can be. So it's an idiopathic inflammatory myopathy with very high prevalence of interstitial lung disease compared to other dermato and polymyositis, and with which it shares many features, such as myopathy can be there too, as you can see. The interstitial lung disease in antisynthetase syndrome patients is often severe, rapidly progressive, and is the main cause of the morbidity and mortality associated with this syndrome compared to any other myositis, inflammatory myositis. So the criteria, I would rather draw your attention to the Solomon and all criteria, as you can see in 2011. So main requirement obviously is presence of the antisynthetase antibody. However, in many articles that I've reviewed, sometimes this antibody, which is almost a requirement, can be negative as well, because the antibody levels can fluctuate according to the disease activity. So a phenotype of a very unexplained interstitial lung disease, along with other findings, may still be very important. So some patients get treated regardless. But anyway, the typical case would be a presence of an antisynthetase antibody, and then one major and two minor criteria. So the two major criteria are interstitial lung disease, and which is not attributable to any other cause, obviously no other cause found. And then polymyositis or dermatomyositis by Bohan and Peter criteria. And the minor one is arthritis, inflammatory arthritis, Raynaud's phenomena, and mechanics hands. So you have to have one major, two minor, or two major would do it, along with the antibody present there. So the treatment plan, obviously, there's not a very clear-cut guidelines how to treat antisynthetase syndrome, but whatever the clinical evidence is, I will present that how we should be treating these patients. So obviously the first step is that, like many other rheumatology illnesses, we start such patients on a high dose of steroids. We can pulse them if they have a very bad lung disease and they're in the ICU. We have done that in the past. And if they have a very bad clinical myositis, but this patient being relatively stable and being there clinically progressive for 2 years, we started him on 1 mg per kg of prednisone, or slightly less than that, 60 milligram per day. And then we started him right off the bat on Cellcept. And we gave him alendronate because we knew that he's going to be on steroids for a while now. We gave him the PCP prophylaxis with Bactrim and vitamin D and calcium. His total CPK, as I said, like what's 227 and ESR 16. On examination, his muscle findings were really, really minimum. So our focus was mainly on his lung disease and inflammatory arthritis and skin findings. So after we saw him, after the first visit when we started him on steroids, he had a good amount of improvement in the symptoms of cough, shortness of breath, and joint pain. And we continued to slowly taper the prednisone, and we slowly increased the Cellcept while everything else remained the same. On August 25th, his cough symptoms continued to improve with only occasional flare-ups. He was able to go back to his singing. He liked to sing without getting short of breath. And his CPK completely kind of not only normalized, it went back to like 56. We continued to taper prednisone slowly. We continued to increase the dose of his Cellcept. And then on September 11, 2020, his shortness of breath has completely much improved, and bilateral crackles have completely resolved. We did the PFTs and DLCO, which came back within normal limits. That is a good sign. And then his CPK again was stayed normal. Prednisone dose has been halved. CellCept dose had increased close to the target. This is his comparison of his pictures. So look at is the clearing of the skin. As you can see, the skin rash on the left side and the skin rash on the right side, within about 2 months, August, September, yeah, within about 2 months, you can see a significant clearing of his skin disease from his hands as well as the knee joints. This is his feet. So from a very severe cracking of the skin and of the sole of the foot, you can see like major clearing of the skin on the right side. December 16th comes and his symptoms of shortness of breath, joint pain, skin have almost resolved. His steroid dose had been tapered down to 7 milligram. His skin disease was coming back a little bit, but otherwise everything was good. The renal functions were normal, liver functions were normal, CPK was normal, ESR was normal, PFTs, as I mentioned with DLC were already normal. So now, as we speak, the skin rash had completely resolved, almost resolved, as I said. Joint pain, stiffness completely gone. Dry cough, almost very minimal, if any. Bilateral crackles have resolved. He's able to do any activity that he wants. He's very happy. And except only thing is that just before coming from Utah on this visit, I found out when I was supposed to see him in the follow-up was that he he actually contracted COVID infection. So luckily speaking, again, we were very worried that he had interstitial lung disease or was an immunosuppressant. So he was thoroughly evaluated, and in the ER, I was called from the ER, and they said that he's relatively stable. I still wanted him to be admitted for a couple of days and just observed, so that his hypoxia, if he doesn't get hypoxia, it doesn't worsen. But luckily he did well. We had to hold his CellCept for that duration while he was in the hospital. So other thing that we can give him in the future, obviously. So multiple drugs have been studied for antisynthetase syndrome. Almost the standard of care is to give them steroids, and then just steroids is not going to slow the progression of the lung disease, which is the major cause of morbidity and mortality in antisynthetase syndromes. So we almost always start them on a concomitant immunosuppressant medication. And the immunosuppressant medication mostly is, Imuran has been studied, which is azathioprine, mycophenolate mofetil, CellCept has been studied thoroughly, and then rituximab. In the standard of care, almost is that you have to start them on steroids and then give them either azathioprine or CellCept, mycophenolate mofetil, which has more efficacy data. Prograf, which is tacrolimus, has been used as an add-on therapy if the patient is not responding. And then rituximab is considered to be a rescue medication. Although I must say that I've used rituximab very frequently on my bad myositis patients with very good results. So I was almost undecided between mycophenolate and rituximab, but since the patient was not very clinically sick with his presentation, and so I went on with CellCept, and luckily he had a pretty good result so far. So the key points is that interstitial lung disease is the most important component, present in 86%. He had subclinical myositis, he had arthritis. Anti-Jo1 is the most important antibody in antisynthetase syndrome and classic antibody. And the other antibody panel, which came back negative, some of those antibodies are important for their own clinical relevance. For example, anti-PL70 antibody can cause severe arthritis. Anti-PL12 antibody can cause pulmonary hypertension and esophageal involvement, and both are associated with severe interstitial lung disease and have a worse prognosis when compared to anti-Jo1 antibody. So these antibody panels are very important for diagnostic, prognostic, and treatment purposes. Anti-EJ can cause dermatomyositis predominance. Anti-OJ, interstitial lung disease, in almost all the patients. And the other antibodies, I've not seen them on the panels very frequently, done commercially available, but they have been mentioned in the literature, which is anti-KS, fever, UIP, anti-YRS, rash and arthritis, and anti-ZO, NSIP, which is non-specific interstitial pneumonia, and then Raynaud's and arthralgias. A few important clinical facts about antisynthetase syndrome: that the patient with ILD, interstitial lung disease, are at additional risk for developing pulmonary hypertension as compared to the patients without ILD. So that is an important thing to monitor. And it's a major cause of morbidity and mortality. So 23.2% may have severe pulmonary hypertension. So in a larger perspective analysis of 233 patients with antisynthetase syndrome, the frequency of cancer was only 1.7%. So we all know that dermatomyositis and polymyositis can put the patient at risk for long-term risk of cancers. But luckily speaking, in antisynthetase syndrome, the risk of cancer was like only 1.7% compared to within 3 years from antisynthetase syndrome diagnosis. And by the way, in this patient, we did do the CAT scan of the abdomen and pelvis just to be on the safe side, and that came back negative. So it's a routine cancer workup, and we also are recommending him to get a colonoscopy. So he'll get his age-specific cancer screening done. In 2015, there were 45 patients were analyzed with antisynthetase syndrome interstitial lung disease, and 14% of the patient had died at 5 years. Survivors were most frequently associated with anti-Jo1 positivity and arthritis. So our patient has a pretty good prognosis in the long run because anti-Jo1 antibody has a favorable prognosis as compared to the other antibody findings. The most common cause of death were pulmonary fibrosis and pulmonary hypertension, as expected. So, antisynthetase syndrome, obviously, I'll come to Pakistan and you can, inshallah, will come to Pakistan and you can ask me questions about that. I would like to move on with my next patient. I obviously, like other rheumatologists in the big clinical centers, I've seen a bunch of very complicated myositis patients with almost all different findings. The reason I want to present this patient is that this was a patient who was very, I'm emotionally connected to this patient because this is a 21 years old African-American female who presented with 3 to 4 months history of very rapidly progressive muscle tightness and weakness, started in the legs. Obviously, she went first to primary care physicians, and there was a lot of wasting of time. She went around to, I think, physiatrist and orthopedic, back, physicians, primary care. She could not explain her symptoms well. She just said that she had heaviness of her body. She could not move her body well. People thought she had chronic back pain issues. But then obviously when she was undiagnosed, her leg weakness got progressively worse. And by the time she came to us, she was unable to get up from the chair on the presentation. And then obviously she would drop into the hospital and for us to work her up. This is a patient I saw in Delaware. And on examination, she had no synovitis, no rash, muscle power was 2 out of 5 in both the upper limbs, so significant weakness. Blood work showed significant elevation of CPK, liver enzymes, ALT, AST, which are not liver, obviously they're muscle in this case. And LDH was raised also, TSH was normal, hepatitis profile was negative. Urine analysis showed obviously blood, but no RBCs, as we all know. This is almost a board question we get asked in any rhabdo patient. Myositis antibody panel was negative. Later on, when it was done at Hopkins, it showed an antibody and TSRP, which I'll talk to you about. EMG came back positive for polymyositis. So your typical run-of-the-mill bad polymyositis patient with very high CPK numbers and very severe weakness on presentation. And her muscle biopsy was consistent with severe polymyositis with necrotizing myositis, kind of findings. Liver biopsy was non-specific. Treatment. So treatment-wise, she obviously, we have the final diagnosis we made based on this was that she is suffering from very bad onset of acute, rapidly progressive polymyositis. And so she was pulsed with a dose of steroids for 4 days. And then she was started on prednisone 1 mg per kg. She made some improvement. CPKs trickled down significantly, but muscle power did not improve. So we put her on methotrexate at that point. She was given some painkillers. She had very dismal improvement after even staying for 2 weeks in the hospital. So at that point, this is a case many years ago, not like recently. So we transferred her to Johns Hopkins, which was only about an hour from our place. And the patient had pretty bad So in Hopkins, they have a very big myositis clinic, which, and I knew some people there, especially Dr. Lisa Christopher Stein, who I have an association from previous patients as well. And the patient was sent there, and over there, they finally found anti-SRP antibody, and the patient was given IV immunoglobulins, which did not work. Finally, she was given rituximab. The patient after rituximab had significant improvement with aggressive rehab and rituximab. She was able to reduce the dose of her prednisone. CPK came close to 1,000, ALT, AST normalized. And then the patient was discharged back to us with a lot of effort. Finally, the patient, where she was not able to even turn her sides in the bed, she was able to get up and was able to first move with the help of a wheelchair. And then she was able to use a walker. That was an amazing thing. I could have never expected that this patient would improve that much. We continue to give her methotrexate and rituximab. Finally, on her choice, and her doing so well, we tapered off methotrexate and just continued the rituximab. But then very strange thing happened. This patient, certainly from being a very perky, very, I would say very happy patient, someone who was very, happy about her life getting improved. She certainly changed her mind. She certainly thought that, okay, all these drugs are toxins, all these drugs may damage, and she could just do her willpower, and she can just use juices and supplements to rehabilitate her muscles. And so this came as a shock. Lisa Christopher Stein talked to her. I talked to her. Her mother talked to her because I knew that this patient otherwise would have a very bad prognosis. But something has happened to her, that she just changed her mind. She was a very active participant of a lot of forums online where she was talking to a lot of myositis patients. And then a lot of pleading, a lot of, requests from us were turned down by her. Otherwise, she had a very clear mind. It was not that she was having a clouding of her judgment or she was some kind of, having an underlying mood disorder or something, but she just changed her mind. And there was there was no convincing that would work for her. And finally, the sad story is that she obviously got admitted to the hospital a few times for worsening of her disease and pneumonia, and she still would not want her to be treated. And finally, she died from her lung disease, from a long protracted kind of hypoxia and lung disease. And all her muscles were replaced by fat, and she eventually died. The patient, interestingly, had wrote her life story before dying, and it's available on Amazon. And she just died in her late 20s. I've seen about 3 patients in my life of anti-SRP antibody, and in fact, the very first patient that I saw in my life when I was doing fellowship years ago was an anti-SRP antibody patient. I was trained at University of Oklahoma, which is there is Dr. Ira Targoff there, who's a world-known authority for myositis antibody panels, and he has discovered a lot of antibodies. And this patient, right off the bat, when I started fellowship, was another African American, very strong man. And the sad story of his is that he was given every treatment that you can think about: methotrexate, azathioprine, rituximab, IVIG, steroids. And this particular patient, while I was doing my fellowship for 2 years, stayed in the ICU from a very strong African-American male. Each time I would be on call after 1 or 2 months, I could not recognize this person. He had changed, he had become weak, he became tired, he had almost all the infections, opportunistic infections you can think about. And before I finished my fellowship, a couple of months before that, he died, actually passed away. So not a good antibody to have. The third anti-SRP antibody patient that I had was another African-American female in Delaware, and she luckily is doing very well. She worked for the state government, and she knew my other patient as well, because all these patients were a part of the myositis, some kind of online community, and that patient also was equally sad about the other, the younger patient dying away, and she tried to talk to her too, but this particular patient is still surviving, doing very well on rituximab. Also a patient, monitored by us and Lisa Christopher Stein, Dr. Lisa Christopher Stein. So anti-SRP antibody myositis, I've already told you about this, associated with very severe and refractory myositis. And along with the typical features on a biopsy are of a necrotizing myopathy. And most of them have chronic progressive muscle weakness of the limb and trunk muscles, young age, and they have mostly a bad outcome if not treated very aggressively. They mostly also develop dysphagia. My patient who in my fellowship died, he also had pretty bad dysphagia. And IVIG kind of improved his dysphagia a little bit, but not much. Finally, they die from the respiratory muscle insufficiency. The third quick patient that I would like to present is another patient that I recently saw. This was a patient who presented with arthralgias, hypothyroidism, skin rash she had, and she was taking only ibuprofen and naproxen for pain. She had no synovitis on examination. I'll be quick about it because there's some interesting part that I wanted to tell. This is the patient I saw after I saw the first patient recently with the mechanics hands. So on this patient, the amazing part was the undiagnosed, went around, nobody could diagnose. She had some chronic flexural contractures that was similar to the presentation of scleroderma, but At the same time, she did not have any scleroderma antibodies that she told me in the other university center she was checked at. But when we examined her, we could find mechanic sand even in her. So, so what I did was that our CPK and liver transaminase were slightly raised. So we ordered the myositis antibody panel, and the myositis antibody panel came back strongly positive for anti-PM-SCL antibody. Very interesting part, because everybody was ordering all the routine scleroderma antibodies like centromere, SCL70, RNA polymerase 3, but the main antibody, which is an overlap antibody, is the PM-SCL antibody. So that came back positive. And so we were pretty thrilled to diagnose a patient which was never diagnosed by other previous rheumatologists. Chest X-ray came back negative for ILD. MRI, the scan of the muscles came back negative. So there was no clinical myositis going on. EMG came back negative for a clinical myopathy. Quickly about anti-PM-SCL antibody is that scleroderma patient with anti-PM-SCL antibodies are typically younger. Typically, they have limited cutaneous involvement, limited skeletal muscle disease, pulmonary fibrosis, and calcinosis compared to the negative anti-PM-SCL negative patients. So they have a relatively good presentation and prognosis. Their 10 years cumulative survival is significantly better in anti-PM-SCL antibody compared to the other scleroderma antibody patients. They're more likely to have Raynaud's syndrome and mechanic hands than compared to any other scleroderma or myositis patient. And mostly they develop heliotrope or goat-run rash, mechanic sand, sclerodactyly, Raynaud's phenomena, and telangiectasias. And our patient had mechanic sand, sclerodactyly, and Raynaud's phenomena. Other cutaneous findings such as calcinosis, 39%, edema, 46%, and puffy hands, 39%. And the GERD is present in 61%, and arthritis 46%, and Zika syndrome 59%. So this was an interesting patient which should not be forgotten. And the good point again is that clinical feature associated with severe scleroderma, such as presence of renal crisis, is pretty low. Hand ulceration 5%. So they mostly carry a good prognosis compared to other scleroderma phenotypes and antibodies. So something not to forget, that if your scleroderma patient is not fitting into the other pictures, and if the antibody testing, otherwise the routine one is negative, think about anti-PM-SCL antibody positivity. And this was our second mechanic hands patient within a span of a few months. So I was pretty excited and thrilled to have back-to-back similar patients with very different phenotypes, very different clinical findings. Quickly, again, I will present this antibody because this is another very interesting patient that I saw. In the beginning, nobody knew about this antibody and this disease. This was my case, and again, which I saw in Christiana Care, where I was the section head for many years, and we saw very complicated patients. Here, this patient I saw about, I think, 10 to 15 years ago, in the very beginning of my, within a, starting my career, first 4 to 5 years. So this was a patient with diabetes, a typical patient of diabetes on on statin medications. So when she came to me, her CPKs were 5,000, and that's why primary care sent to me. There was almost no clinical weakness, that I couldn't find. So I said, it's not like a clear-cut myositis. Maybe it's due to statins. I stopped her statins. I repeated her CPKs. There was no real improvement, but there's no major muscle weakness also. So I did not know what to do because I felt okay. This is just a clinic, some damage, and it may just take some time to resolve. So a few months later, this patient was wheeled into my office, now completely crippled. She could not walk, or she in fact fell in our office also while she was trying to get up. So clinically significantly weak. We ordered the myositis panel. It came back negative. I was kind of frustrated about this patient, so I sent this patient to Lisa Christopher Stein. In fact, that's how we kind of had an association developed with her because she was at that time working on a very unique kind of antibody, which we call anti-HMG-CoA reductase antibody, which is basically, again, so these statin drugs that we take. Now, Lisa Christopher Stein has a whole case series of these patients. At that time, she had a handful of patients, and my patient was one of the earliest patients in our first published case series, that there is certain genetically predisposed people who can have, when they take statins as compared to other people, can trigger an autoimmune antibody phenomena where you can actually recognize this antibody that Lisa Christopher Stein, in fact, discovered, that this particular antibody can then trigger an autoimmune phenomena, which is ongoing, which is progressive, which does not even stop when you have to remove the statin drugs. So I felt this was a very exciting antibody to be like a clinical patient to be found at that particular point. And so this is something to be recognized because we use a lot of statins. Still, most of the statins are not going to do this. It's only a few patients where you feel that, the CPKs are very high. There's severe muscle weakness. It's not going away even after you remove the statin. Strongly think about it. And this is another autoimmune myositis where when you do the biopsy, it also is necrotizing myopathy along with anti-SRP. So remember this: when there is a necrotizing myopathy, think about two things at least: this particular disease and anti-SRP antibody disease. So the presence of HLA-DRB DRB1 1101 allele is a well-established immunogenic risk factor for developing this disease. Originally identified almost in 70% of the patient. Now it has been validated in multiple cohorts with different racial and ethnic origin. I don't know whether it's available, commercially to be tested, but this obviously will be eventually something that we can use to differentiate the patients who can have statin-induced myopathy versus routine myopathic damage from the statin drugs. IVIG is, so our patient got, in fact, she got everything there as well. But finally, what really made a difference was IVIG, and which my patient received as well, and she was doing pretty good eventually. So I would actually like to stop here. I have a lot more cases too, but I feel that I should stop here for the sake of time. And inshallah, when I come back to Pakistan, I will like to participate in that live discussion, and where we can discuss much more about myopathy and all the illnesses. I have a bunch of other very interesting myopathic and autoimmune myositis patients which we can discuss, and we can all have a very good interactive discussion, inshallah. And again, thank you very much for allowing me to participate in this conference. And thank you for the whole audience, and thank you to Dr. Tafazul and his team.